I'm a fourth-year resident in OBGYN. This is a huge topic that really hits home with a lot of different people. So I'm really glad that I get to talk about this with you guys. I have a specific interest in infertility. I'm actually moving to UNC this summer and doing a fellowship in reproductive endocrinology and infertility. So this is going to be my specialty in a few years. Without further ado, what I'm going to be talking with you guys today is kind of going through infertility. What is infertility? What is fertility? What's normal? What's not normal? And how do we treat all the different things that can cause infertility? We'll go through several different scenarios and steps that you should take if they apply to you. And we'll also cover some myths that are commonly heard. Towards the end, we have a video from a UK physician where she essentially tells her own personal story as a patient with infertility. And then at the very end, there will be time for question and answer. So when it comes to talking about fertility, doctors often use the word fecundity. And this is the monthly probability that you'll conceive in the setting of unprotected intercourse. Normal is defined as somewhere between 15 and 20%. And there are a lot of studies that show that over the course of a year, couples who have regular unprotected intercourse, about 85 to 90% of them will get pregnant. So technically, we define infertility as the inability to conceive after 12 months of unprotected intercourse. Given this, math, about 15% of couples will have infertility. It's unfortunately a really common problem. It has a wide range of causes and treatments, and it can cause significant distress to patients and couples across the world. Of note, even when couples don't get any medical help, about half of couples who don't get pregnant the first year will get pregnant the second year. And then I don't want the 12 months to kind of, that be the limit to say, I shouldn't receive help for my infertility until it's been 12 months, because really it depends on a lot of things. For example, when women are 35 years or older, they should be evaluated and treated for infertility just after 6 months. It's important to understand that fecundity decreases starting when women are about 32 and then goes down even more by the time they're 37. There are a lot of causes of infertility, like I mentioned. It can be caused by problems that are specific to either males or females, and we refer to this as either male or female factor infertility. So about 30 to 40% of the time, the infertility is due to the female. About 30 to 40% of the time, it's due to the male. For whatever reason, oftentimes people who have infertility tend to find each other, and that can be difficult as well. That happens about 20% of cases. And then still in about 10% of the time, we don't know what caused the infertility. Because I'm an OBGYN resident, most of my stuff is going to be focused on female factor infertility. So in talking about infertility, I thought that it would be helpful if we first went through to talk about everything that needs to happen for fertilization and for pregnancy to happen. That way we can talk about what can go wrong at each step and what we can do to treat at each step. So the first thing that you need is for your ovary to release an egg every month. You have to have a good supply of eggs, and the eggs have to be of good quality. The next thing that has to happen is that there has to be quality sperm that can find its way to the egg. The sperm count has to be high enough, and there have to be enough normal moving sperm so that at least one can make it to the egg. You also need to have open tubes or patent tubes where the egg and the sperm can meet and fertilization can take place. And then lastly, you have to have a place for the embryo to implant and grow. This space is called the endometrial cavity. It's kind of what's on the inside of the uterus where the embryo would implant. So now let's go through each of these steps and talk about how each one impacts fertility, what can go wrong at each step, how we diagnose these problems, and how we can treat these problems. So first, in order to get pregnant, you have to release an egg each month. This is called ovulation. And you have to have the right hormone signaling in place in order for your body to initiate ovulation. You have to have a normal number of eggs, they have to be of good quality, And something can go wrong with each of these three parts. So first, what does it mean to ovulate? We'll start with a little background information. This is a super scary chart that OBGYNs often use, and it's way more detail than I want to get into, but there are a couple basic principles that are illustrated here that carry on into understanding infertility. At the bottom of the chart, you can see that when we talk about the menstrual cycle, day 1 is the first day of your period. And then around day 13, 14, in the very top row, you can see that teal peak. That is called the LH surge. That is essentially the hormone signal that triggers you to ovulate. If fertilization doesn't occur after you ovulate, you then go on to have a period. So based on this information, we know that if you're ovulating, then you're having regular periods. This tells your doctor that all the hormone signaling processes are there for you in order to release an egg each month. Another way to know, even if you're having periods, is to use something called ovulation predictor kits, or OPKs, like the one that I've got pictured in this slide. They're over the counter, they look like pregnancy tests. There's a bunch of different brands and varieties. I would recommend getting a simpler one, not one that says, it's almost time for LH surge, but really just one that says plus or minus. The goal of these kits essentially is to measure when and if the LH surge that we talked about in the previous slide, when that happens. So let's say that you bought an OPK and you found out that you ovulate on day 13 every month. What do you do with this information, and how can it help you when it comes to your fertility? When you're trying to get pregnant, the scenario that is most likely to work is to have sperm already present when you ovulate. Sperm lives a while. It can live like 3 to 5 days in the female reproductive tract. So what I often tell my patients is to have, if they ovulate on day 13, for example, is to have intercourse on days 8, 10, 12, and 14. On the other hand, the egg doesn't live longer than 24 hours, so the best time to have intercourse is before you ovulate. So given all that, the best way to use an OPK, or an ovulation predictor kit, is to identify when you ovulate so that the following month you can have unprotected intercourse in the days leading up to the day that you know you're going to ovulate. Next, the number of eggs that you have is important. The maximum number of eggs that you ever have is when you are still a fetus. When your mom was about 20 weeks pregnant, you had about 7 million eggs. By the time that you were born, this went down to 2 million. By the time you hit puberty, this was 400,000. And over the course of your life, women ovulate about 500 times or less. Unfortunately, the only way to really answer the question is, do you have a normal number of eggs, is with the doctor's help. There are a lot of different tests that can be done in different situations. FSH, or follicle stimulating hormone, tells us if you've entered menopause, and that's why you aren't ovulating or releasing eggs. Anti-Mullerian hormone, or AMH, is technically a marker of how many eggs we think we could collect if you were undergoing a cycle of IVF. It's not studied to tell us what your chances are of getting pregnant on your own, but oftentimes OBGYNs will sort of use it that way. By that I mean, if you go to see your doctor and you get an AMH and the result is really low, then they are more likely to refer you to a specialist because they're worried about how much reserve your ovary has. Antral follicle count is part of an ultrasound, and it looks at how many developing eggs are on each of your ovaries, and that can also give doctors an idea of if you have diminished ovarian reserve or fewer eggs. It's also really difficult to test egg quality. And egg quality itself can refer to a lot of different things about the egg. It can refer to the way the egg looks. It can refer to the genetic material. It's well documented that the quality of eggs decreases with age. The rate of genetic or chromosomal abnormalities increases with age. Both of that affects, both the increased rate of infertility, but also the increased miscarriage rates, which I have here in this table. You can see the rate of miscarriages increasing as women age. Infertility also goes up with age. Only about 8% of women who are 20 to 29 years old have infertility. That goes up to 15% when they're 30 to 34, 22% when women are 35 to 39, up to 30% by the time women are 40. Diagnosing abnormal eggs is also hard. When women have had multiple miscarriages, doctors can test the parent's genes by doing a genetic test called a karyotype, looks at the parent's chromosomes. This is often one of the very last things that your doctor will do, and that's because this blood test has to be done on both parties in the couple, and for each one, it can cost over $2,000. Another option is something called pre-implantation genetic testing, which we'll talk about in the next slide. But essentially, if we're concerned about the genetic material, an embryo is biopsied and the genetic material is tested for chromosomal abnormalities or specific genetic problems that, say, might run in your family. So after all that, if you realize that you aren't ovulating, the question is, why aren't you ovulating and what can you do about it? When I say chronic anovulation on this slide, what I mean is any condition in which a woman does not ovulate for a longer period of time. One of the most common causes is something you've probably heard of. It's called polycystic ovarian syndrome, or PCOS. Not all women with PCOS struggle with being overweight, but some do. And obesity in itself can absolutely also affect your ability to ovulate. Lifestyle changes can make a huge difference when it comes to weight. If you're overweight, losing even 5% of your body weight can increase the chance that you ovulate by as much as 50%. This does not mean that your goal should be to be skinny, because it's actually quite the opposite. Women who are underweight have an even harder time getting pregnant than women who are overweight. One study actually looked at kind of what the magic number was for BMI. There was a specific BMI where they found that women had the least rate of infertility, and that number was 24. But, to be clear, PCOS and weight imbalances are absolutely not the only things that cause women not to ovulate. There are lots of other imbalances and hormone problems like a high thyroid, a low thyroid, a high prolactin. All of these things can impact your ability to ovulate. These are all things that your OBGYN can test for and can help you treat. Women who don't ovulate might need additional help when it comes to getting pregnant, as is often the case with patients who have PCOS. There are a lot of different medicines that can be used, and the two most common are letrozole and Clomid. Both of these medicines work in different ways, but essentially the end goal is to affect the hormone signaling to your ovaries and increase how much you ovulate or help you ovulate at all if you're not ovulating without it. Doctors use them each in specific clinical scenarios, and they both have their own risks, but really the biggest risk that they both share is the risk of having twins. Oftentimes I'll have patients say, oh, well, I want twins, but as an OBGYN, what I want for my patients is a healthy mom and a healthy baby. And that means as low of a risk pregnancy as possible. And having twins is a higher risk pregnancy. So it's an important risk to know and to talk about. There are a lot of other hormones that can be used, but that's beyond the scope of this talk. And these medicines, the letrozole and the Clomid, and these other hormones I mentioned, they can be used alone, or you can also use them in conjunction with something called intrauterine insemination, which we'll talk about more later. But essentially, we do this in order to remove as many barriers as possible to fertilization. So if we're giving you medicine to help you ovulate, we can also place the sperm directly in the uterus to decrease the distance that the sperm has to travel. IVF can also be used to stimulate the ovary, and that removes even more barriers. In a nutshell, IVF means that we give a patient a series of hormones, have them mature a bunch of eggs, which we then collect. We fertilize the eggs with sperm and then put them in the uterus. If the egg quality is a barrier, remember the genetics that we talked about, then here is the option for pre-implantation genetic testing, or PGT, where the embryos are tested before we implant them in the uterus. If the number of eggs obtained or the quality of eggs obtained through IVF don't suffice, then there are alternatives, and that includes using donor eggs or even donor embryos. Okay, so we've talked about ovulation. The next thing that you have to have is sperm. Semen analysis is one of the most standard parts of an infertility workup. It looks at both sperm form, sperm function. It can help direct treatment too. First, it's important to recognize that sperm has to be present at the right time in order for fertilization to occur. Like I mentioned before, sperm can live for a long time in the female reproductive tract, and the egg doesn't survive near that long. Therefore, it's ideal for sperm to already be present when women ovulate, which typically happens, like we previously mentioned, around day 14 of the menstrual cycle. A semen analysis can tell us a lot about sperm, and there are different things that doctors look at in a semen analysis. Some of those things might include the sperm count, the sperm concentration, but also motility, meaning are they moving, and are they moving in the right direction, and also morphology. It's very normal for most sperm to have some abnormal feature, but we want at least greater than 4% to appear normal. Patients can have a combination of these, and a lot of different things can contribute to an abnormal semen analysis, like certain medications or supplements. So because of this, if somebody has an abnormal semen analysis, typically what should be done is to go through the male's history and medications, but also to repeat the analysis. If the analysis continues to be abnormal, the next step is to refer to a specialist like a urologist. If indeed we diagnose the couple with male factor infertility, then the goal is to remove as many barriers as possible to fertilization. Sperm's got a long way to go. It's got to go through the vagina, the cervix, the uterus, the tubes, and removing barriers can come in a couple different forms. One can be placing the sperm directly in the uterus, which, like we mentioned, that's called intrauterine insemination, or IUI. Another form would be IVF and having the sperm fertilize the egg. Or alternatively, when we're doing IVF, we can directly inject sperm into the egg, a procedure called intracytoplasmic sperm injection, which is what this is a picture of. If a patient has mild changes in the semen analysis, oftentimes the first step can be sperm washing and IUI. But if a patient has severe male factor infertility, oftentimes that means that you have to go straight to IVF or ICSI, as the chances of getting pregnant spontaneously would be really low. Next, you have to have open tubes for the egg and the sperm to meet to form an embryo and then to travel to the uterus. There are a lot of different reasons why somebody might not have open tubes. First, scarring inside the belly can happen after surgery. It can happen after infections. It can also happen with endometriosis. Infections like pelvic inflammatory disease not only cause scarring inside the pelvis, but specific types of infections like chlamydia have been known to cause scarring within the tubes themselves. Alternatively, if one end of the tube is blocked, what can happen is fluid can collect in the tube and essentially make it swollen. This is called a hydrosalpinx. Not only does this lead to a tube that doesn't work, but it also releases inflammatory factors into your uterus that can further impact your fertility and make it harder for you to get pregnant. We diagnose tubal factor infertility by something called a hysterosalpingogram. This is where we inject dye into the cervix and watch it go up the uterus and then out the tubes. You can see in the picture on the left that this patient has open fallopian tubes on both sides, whereas the one on the right only has one open tube. Other procedures that we can do to help in diagnosis is a diagnostic laparoscopy. This is a minimally invasive surgery. We often do it if we're suspicious for something like endometriosis. It can help us identify and make the diagnosis of endometriosis. It can also help us take down scar tissue if that's contributing. Another part of a diagnostic laparoscopy could be something called a chromatubation, which is where we inject dye through the cervix at the time of surgery. And then while we're looking inside the belly with a camera, we can watch the dye come out of the tubes. If we diagnose tubal factor infertility, there's several things we can do. First of all, if a patient has hydrosalpinx, taking the tube completely out is shown to increase the chances of a patient getting pregnant. So if somebody has hydrosalpinx, the recommendation is to take the tube out, called a salpingectomy. If somebody has both tubes that don't work, then the next step would be to essentially bypass the tubes, and that would mean in vitro fertilization. I have had patients in the past who've obtained a tubal reanastomosis, meaning that they've had a tubal in the past and then wanted to get pregnant, and so they had it reversed. This is something that's not commonly done anymore, and the success rates for a tubal reanastomosis and IVF are about the same. And so at this point, most providers are only offering IVF. Okay, so then we've talked about ovulation and sperm and tubes. The next step is to talk about the endometrial cavity. This is where the embryo has to go to implant. Abnormalities of the uterus can contribute to patients having a hard time getting pregnant. Uterine fibroids are one of the things that can do that. Essentially, they can distort the endometrial cavity, which is that space inside the uterus where the embryo implants, and that can make it hard for implantation, but on the other hand, it's also treatable. Something else that can cause uterine factor infertility is scarring inside the uterus, and that can be scarring from surgeries or adhesions from having infections before. Something called Asherman syndrome is a term that we use to describe scar tissue in the uterus. This can be mild, this can be severe, but it is treatable with surgery. And then sometimes an abnormality of the uterus is actually present before you're born. The uterus and the fallopian tubes may not form correctly, and these are called Müllerian anomalies. There are a lot of different kinds, and they range from the most severe being agenesis, or complete failure of the uterus from forming, to duplication, which is called a didelphys. The most mild of these is called a septate, which you can see at the top left picture. There's just a fibrous band going down the uterus. Oftentimes, these are avascular, meaning there's no blood vessels in them. So what happens is someone is trying to get pregnant, the embryo goes inside the uterus to try to implant, and might implant on the septum. But the septum, remember, doesn't have blood vessels, and so the embryo isn't able to implant correctly and isn't able to develop. This is also really treatable, and I'll talk about that here in a second. There are several ways that we can evaluate a patient's uterus and the endometrial cavity for any of the things that we've talked about. One option is a 3D ultrasound that gives us a better view at the anomalies of the uterus, like fibroids and polyps. Another option is something called a saline-infused sonohystogram, which is a test that uses a combination of both ultrasound and placing a sterile fluid inside the uterus, like water or saline. You can see that in the top right picture. And this allows us to kind of blow up the uterus and take a better look at what's going on inside. The bottom picture is the ultrasound of someone getting an SIS, and that you can see that they have found a fibroid inside the uterus. Another way to make these kind of diagnoses is something called hysteroscopy. This is a type of surgery where we take a very small camera and we look through the cervix into the uterus to look for any anomalies or irregularities. If we find an abnormality of the uterus that distorts the endometrial cavity, then what do we do about it? Well, it depends on what it is. If it's a fibroid, the treatment is myomectomy, which is fancy doctor talk for just saying we're going to take out the fibroid. It's important to understand that women can have fibroids in a lot of different places. Sometimes the fibroids are outside the uterus and don't impact the endometrial cavity at all. These fibroids typically don't affect fertility. But if someone has fibroids that are inside the uterus or that are distorting the shape, sometimes that can contribute. If someone has fibroids and has a hard time getting pregnant, then this can be treated by removing the fibroid. The way we remove the fibroid depends on where the fibroid is and how big it is. One option is doing it with a hysteroscopy, which, as I mentioned, was a really small camera through the cervix. Another option, if it's bigger, is doing it abdominally with an abdominal incision, or laparoscopically, which is a minimally invasive approach. Other things like a septum can also be removed using operative hysteroscopy, meaning we can just take scissors when we're using the camera and just kind of snip the septate out. And similar things can be done for things like polyps and scar tissue. So in summary, we have talked about everything that needs to happen in order to get pregnant and how each of these steps can go wrong and what to do about each one. We talked about how you have to release an egg every month. You have to have a good number of eggs, good quality of eggs, and things that we can do to help when it comes to problems with ovulation is give you medicine to help you ovulate, and also to several labs to look at your ovarian reserve, and also things like IVF, where we can help kind of recruit eggs to help you get pregnant. We talked about having open tubes is important, how to diagnose it, and that if you have a hydrosalpinx or those swollen tubes, those should come out if you're trying to get pregnant. Or if you don't have functioning tubes, then the next step is IVF. We talked about implantation as well and the different things that can go wrong inside the uterus, as well as sperm and the different abnormalities that we can see with sperm counts, and how decreasing barriers to fertilization is what we would do to help. And that can come in the form of intrauterine insemination, or even ICSI, which, remember, is when we inject the sperm directly into the egg. The next thing that I wanted to do is to go through some frequently asked questions and common scenarios to go through. The first one is, let's say you want to get pregnant. What do you do next? What's the next step? Before pursuing pregnancy, let alone any infertility treatment, it's important that a patient's health status be optimized. Not only from an optimizing fertility standpoint, but also from a healthy pregnancy standpoint. This means having the right vaccines, having the right genetic screening. These are all things that you can talk about with your OBGYN, something called a preconception counseling visit. Other topics you guys might talk about are things like diabetes, infections, making sure you're taking a prenatal vitamin and folic acid, weight loss, weight gain, smoking cessation, and talking about any other drug use. You can see from the table on this slide that being overweight, underweight, smoking, drinking coffee, all of those things affect fertility. Before you try to get pregnant, your doctor can address all of these things with you. If you have a medical problem, I often recommend that my patients have their PCP or their family doctor on board to make sure that all their medical problems are optimized. The other thing that's important is that if you're on medications for things like high blood pressure, you want to make sure that you're on medications that are safe for pregnancy if you are actively trying to get pregnant. Next is, let's say that you're having trouble getting pregnant. What should you do next? Infertility is common, but it's not always talked about, and people often feel really isolated. Not just that, but it can be really taxing on relationships. So when I talk to my patients about this, I want to make sure that they have a good support system, that they have people that they can talk to and go to. In line with this, consider getting a counselor. If you're part of a couple, consider getting a couples counselor. And just because it hasn't been a year or 6 months of you having regular unprotected intercourse doesn't mean that you shouldn't go see your OBGYN about it. As we talked about, there are a lot of things that can go wrong, and some of those are easily treated. So when you go see your OBGYN, there are several things you should bring. One of those is your menstrual calendar. Essentially how we talked about earlier, where day 1 of your menstrual cycle is the first day of your period. Keep a calendar so that you know when you have intercourse and when you ovulate. This can help your doctor give you further direction. Other things to bring are any other lab work that you've had, whether you saw your family doctor and they tested you for diabetes or they tested your thyroid. Those are all things that your OBGYN is going to want to know. If you've had any ultrasounds, those are important to bring too. And if you are an overachiever and have already gotten a semen analysis, then bring that as well. Now, unfortunately, a lot of infertility workup and treatment is not covered by insurance. So I would recommend knowing what your insurance covers ahead of time. I know that the UK HMO does not cover most infertility treatment or workup, but I do want to make a point that if there's a medical condition that's causing infertility, insurance does treat that. For example, if somebody has significant pain and painful periods and they've been diagnosed with endometriosis, and we need to do surgery for endometriosis, insurance would cover that, and kind of an effect of that is that it might help fertility. I also want to make a note that while Kentucky is not a mandated state, meaning that insurance is not forced to cover infertility, there are specific opportunities in Kentucky to get insurance that does cover infertility. Some employers like Starbucks covers infertility, so I've had patients actually get part-time jobs or full-time jobs at Starbucks on the side just to get the benefits. Lastly, depending on what your OBGYN says, or if you just want to go straight to a specialist, what you need to look for is a board-certified reproductive endocrinologist, or REI, for reproductive endocrinology and infertility. Next scenario is, let's say you and your partner are LGBTQI. What are your options? In the setting of an LGBTQI couple, there are several different options for different scenarios. It just depends on what part of the equation is missing. If you need sperm, then there are a lot of sperm banks that you can get anonymous donor sperm from. Allows you to choose many qualities of anonymous sperm donors, like hair color, eye color, education, genetic screening, all of these things. and this sperm can be used for IUI or intrauterine insemination and IVF. Anonymous sperm donor is definitely the easiest, safest, not to mention cheapest option. The other option that some patients go for is something called a known sperm donor, meaning they want to use sperm from somebody that they know. This can be a little bit more medically, legally, and ethically challenging. For some people, it's the right answer, but for a lot of other people, this is a significant challenge. There are more FDA hoops to go through if this is what you choose. And because it can be such a challenge, a lot of REI practices can't support it. If what you need is a donor egg, then you also need a surrogate. This is an even bigger financial undertaking, and the surrogate can cost upwards of $40,000. Alternatives, of course, include using a donor embryo, and what this refers to is leftover embryos. When a couple goes through IVF, if they don't use all of their embryos, then they can decide what happens with the embryos, whether that means they're discarded, whether that means they're donated to research, or made adoptable. Adoption, of course, is also an option. The last scenario that I wanted to go through is, let's say that you're single and you're concerned about your fertility. What should you do? If you're single and you want to get pregnant right away and you're worried about your fertility, a good first place to start is your OBGYN. They can answer a lot of questions for you. They can help you come up with a plan. When it comes to family planning in this situation, there are a lot of questions that you need to be prepared to answer, and you need to think about what's important to you. For example, is having a partner a must for getting pregnant, or would you desire to get pregnant not as part of a couple? If you want to get pregnant right away, either your OBGYN or an REI can help you navigate selecting sperm from a sperm bank and also doing IUI. If you're single and you're worried about your fertility, but you don't want to conceive the next couple years, then there are several other things you need to take into consideration, one of those being your age. If you're less than 32, that means that you probably don't need to make any decisions right away. But the next question you need to ask yourself is, do you want to freeze your eggs? There's no right answer, there's no wrong answer, just a lot of options and things to consider. Freezing your eggs does not guarantee that you will get pregnant in the future. But like we talked about, egg quality decreases with age, and freezing your eggs preserves your egg quality at the age that you are when you got them frozen. It can also provide you with a significant peace of mind. You know, a good person to talk to about this more would be a reproductive endocrinologist. Lastly, I wanted to go through some myths that I commonly hear when it comes to fertility. First one being that it's always the woman's fault, which is clearly not true. A third of the time it's the female, a third of the time it's the male. And then for whatever reason, these people tend to find each other, and about 20% of the time it's both partners. There are factors that can be attributed to both partners. The next myth that I hear often is having sex every day increases your chance of getting pregnant. This is not true. So if you remember, we talked about you want sperm to be present when you ovulate. Let's say that's on day 14. Having sex every day decreases the sperm count. So if you started having sex on day 5, and you have sex every day until day 14, the sperm that's going to be there on day 12, 13, that's going to be the lowest sperm count, which is not what you want, because that's going to be the sperm that's there when you ovulate. To really increase your chances of having quality sperm present when you ovulate, the best thing to do is to have sex every other day. Third, I've also heard that having an abortion causes infertility. This is not true at all. Having uterine surgery does not increase your chance of infertility. The chance of scarring from having surgery inside your uterus, abortion or not abortion, is very low. The kind of surgery that specifically increases the risk of scar tissue is if you just had a baby and you start bleeding really heavily and they have to take you to the operating room to empty your uterus. That specific scenario increases your risk of having scarring inside the uterus, but abortion does not. Lastly, if I want children after 35, I have to freeze my eggs. This is not true. If it is a very personal decision, and there is no right answer and there is no wrong answer, but it's something to think about, and it depends on what's important to you. If you want to talk more about, freezing your eggs, you should establish care with a reproductive endocrinologist. So lastly, I wanted to leave you guys with kind of resources that are available and things that you should do from here. And one, like I mentioned, is have a support group. It's so important. And certain REI practices actually mandate that their patients have a counselor because this is really emotionally taxing. There are specific providers here in Lexington that you can see. There's the generalist or general OBGYN division here at UK. One of those physicians, Dr. Rohn, will do things like hysterosalpingograms, which if you remember, that was a test where we put dye inside the uterus and looked at the tubes. He will do intrauterine insemination, but it's very difficult to get that organized here at UK. So I would actually recommend that you go to a reproductive endocrinologist for that. Other things that Dr. Rohn can do is surgeries for things like endometriosis. When you're looking for a reproductive endocrinologist, you want someone who's board certified. There is only one of those in Lexington, and that's Dr. Aiken. There are a couple really good practices in Cincinnati. It just matters on whether or not you're willing to travel that far. Another thing that's really useful is apps on your phone, especially when it comes to tracking your period. This can make it way easier than using pen and paper. And when it comes to finding support groups or more information from a patient standpoint, resolve.org is a really good resource. It's this national infertility association. It's really great for getting involved in advocacy, such as make states mandate insurance coverage for fertility, but it also helps find local support groups and kind of basic infertility information. ASRM is kind of the national reproductive medicine organization, and you can find a lot of really good patient information on there as well. So the next thing I'm going to do is show you guys this YouTube video. I'm going to hope that this works. Okay.
Hi everyone, this is Tubal Infertility. Coming to you as a patient.
Oh, I hear you guys can't hear the video. Is that right? Okay. Let me try one more thing. If that doesn't work, this link will be in this PowerPoint, so you guys can kind of. How about now?
This is Tubal Infertility.
Can you guys hear that? Oh, okay. All right. Essentially, she has a really interesting story, and I'll let you guys watch the video, but she and her wife wanted to use a known sperm donor, which, like we talked about, is a little bit more challenging. And so she talks about some of the struggles that she had to go through in order to do that. It's a really good story. I'd recommend that you guys kind of watch this video. And then that concludes my talk. Let me find my way back to the chat. Oh dear. And that way we can kind of go through some questions. Okay, can you guys see now? Yeah, I'm happy to answer anything. So that's a really good question, and it depends on a lot of other things. But when you're looking at letrozole or Clomid, there are studies that show that letrozole is actually has a higher chance of pregnancy, we use letrozole over Clomid. Clomid is better when the reason for infertility is unknown. And then there are actually some newer studies that are looking at using both of them at the same time. But if you have PCOS, I would say use letrozole. And it also depends on whether or not you're using letrozole by itself or if you're also including IUI and how long you've been trying to get pregnant. If you've been trying to get pregnant for, let's say, 2 years, the chance of you getting pregnant on your own is probably pretty low. Using letrozole can increase that by, it's really hard for me to give a number, but I would say less than 10% by itself each month. No, so if you have really irregular periods, I don't, if you should see an OB/GYN, because really the thing is that if you have irregular periods, you know, one of the most common causes that we see is PCOS. And if you have PCOS, you're not ovulating. You might have really irregular bleeding, but it's not because you're ovulating. When people have PCOS, often what we'll do is we'll give them something called Provera, and that'll kind of give them a fake period so that we can have a day one. And then we'll go based off of that and then give you letrozole or Clomid. But if you have PCOS, I would not start with taking OPKs. That's a really good question. I know that there are counselors here at UK, but I don't think that there are any that are familiar with infertility. Yeah, no, that's a really good question. I mean, I don't think people talk about how emotionally taxing it can be, and I think it would be a really good resource. Oh, that's a really good number. I mean, good question. I don't have a specific number for you, but it's really common. That's a really good question. A polypectomy, definitely not. A polyp is essentially an overgrowth of the inside of the uterus called the endometrium. And so that kind of surgery, removing a polyp, is very superficial. A fibroid removal likely doesn't cause scarring within the uterus, but it, depending on what kind of fibroid is removed, can weaken the wall of the uterus. That's why, depending on what kind of fibroid you have and what kind of surgery you have to have it removed, if you get pregnant and you go on to deliver, oftentimes your physician will recommend a C-section, just depending on how the fibroid was removed. It's a surgery that has its own risks. That's why we say, if, you know, the only time that you should really think about removing a fibroid for fertility is that if you've had infertility and you know that this fibroid is impacting the endometrial cavity. So it's a really good question. It depends on what kind of ovarian cysts you have. Oftentimes, people who have ovarian cysts actually have functional cysts, meaning that they're ovulating and then the ovary is just having a harder time kind of reabsorbing the cyst after they've ovulated. And so those don't impact, but if you have kind of a really big cyst, that can impact how much of your ovary is working. And specifically, if you have something called an endometrioma, which is a cyst that results from endometriosis, that can specifically affect your fertility. So depending on what size it is, some reproductive endocrinologists will actually recommend that you have it taken out or you have it opened.